start this off. Kuskaha kulan chutin in konmith piayat de skedel piat des nexulacha in konmith the tum hula the tumik the marimson the sust the sukmayam the sukmarim the ilamicham the saljas. Ask the Creator to bless each and every one of us, and the earth and what the Mother Earth shares with us, the animals, the foods, the medicines, the water, for all of our people. We want to pray that we have a good meeting today, as prayers for our elders, our teachers, for the ones that doctor us, not only our spirits but our physical bodies, for our soldiers that might be in harm's way. Ask you to send a warrior spirit and help guide us and lead us and protect us, and pray that they return home safe, and when they make it back home that they're in a good place. I always watch over them, the good warrior spirit. For those that are mourning and lost loved ones, watch over them, give them strength to make each day a little bit easier. Pray we have a good meeting today, and that all of our leaders here, the leaders from all of the departments, that together we'll do good work for all of our people. Whitelam, thank you. First of all, I want to welcome everyone here. I'm going to try to keep the meeting as on task as much as we can. We do have some hard stops that we'll actually have to stop, and I don't mean to cut anybody off, but it's the people's time are very important at this place. So when we have to have those hard stops, it's for a reason. It's not to be offending anyone. We have a hard stop at 10:30, and that's for the HHS budget update. And we have another hard stop for the swearing in at 11:30. But right now we'll go through introductions. So if we could start off here, and we'll work our way around this way.
Thank you very much, Andy. Nicholas Lewis, I'm a council member for the Lummi Nation in Washington State. I'm also the chairman of the Northwest Portland Area Indian Health Board and vice chairperson on both the National Indian Health Board and Tribal Self-Governance.
Oh, there we go. Sorry. Beverly Lofton. I'm with the Centers for Medicare and Medicaid Services. I'm a senior policy advisor, and I work in the tribal affairs area.
Good morning, everyone. I'm Kitty Marks. I'm the director of the Division of Tribal Affairs at CMS. Good to see everybody.
Zombachwa. My name is Claudia Washke. I'm the business council member for the Fort Hall Business Council with the Shoshone-Bannock Tribes.
Good morning. I am Shay Welch from the Centers for Disease Control and Prevention. I am Blackfeet, and I am the acting director of the Office of Tribal Affairs and Strategic Alliances.
Good morning. I'm Robin Kawazoy. I'm from the National Institutes of Health. I'm the acting director of the Tribal Health Research Office, and I'm the deputy director of the Division of Program Coordination, Planning, and Strategic Initiatives in the Office of the Director at NIH.
Good morning. My name is Ivy Vedamuthu, and I'm the acting director of the Office of Tribal Affairs at the Health Resources and Services Administration.
Sego Skanagolagang, Michelle Sava Yanyats. My name is Michelle Sauve, and I am the Executive Director of the Interdepartmental Council on Native American Affairs. But today I'm here to represent the Administration for Children and Families when we go through the HHS 101.
Saguli Swagwake, Jennifer Webster, Niyungets. Good morning. I'm Jenny Webster from Oneida Nation in Wisconsin, and also represent the Bemidji area. Thank you.
Morning, everyone. My name is Tyler Anderson. I work in the Office of the Assistant Secretary for Financial Resources here at HHS, and I am the budget analyst that covers the IHS budget. I'm also currently serving as the acting branch chief for the Public Health and Social Services branch, which covers the budgets of IHS, HRSA, SAMHSA, ACL, and ACF. Glad to be here.
Good morning. My name is Kim Beniquez, and I work in the SAMHSA Office of Tribal Affairs and Policy.
My name is Rufus Arnold. I am a council member from Makah, and I'm new.
Ashita Sheets, Terry Parton, Dadit City. I said, how are you all? My name is Terry Parton, and I'm president for the Wichita and Affiliated Tribes. Thank you.
Marvin Figueroa, Director of the Office of Intergovernmental and External Affairs.
If there's any other tribal leaders, please join us at the table. All right, I'm not seeing any. I want to welcome Marvin Figueroa, and he's going to do the opening remarks. He's the Director of Office of Intergovernmental and External Affairs.
Thank you, Councilman Joseph. The benefit of going last during introductions is that you learn how to use the microphone. So good morning, everyone. Councilman Joseph, thank you for chairing this meeting. And I'm so excited to be here with you all today, and welcome to your HHS. This is the first in-person HHS tribal consultation over 3 years. I think it's often important for us to kind of let that sit for a little bit and recognize how fortunate we are to be in fellowship and be able to see each other face to face and not a small box in a screen. And more than that, this is the 25th year in meeting with tribes to consult and hear your recommendations into the HHS tribal budget formulation. I want to thank all the tribal leaders who were able to travel to be in person with us today. And for those who join us on the screen and online, we look forward to seeing you next year. I am extremely proud of the fact that HHS is one of the few departments whose tribal consultation policy actually requires us to consult on budget formulation. And I'm happy to say on behalf of Secretary Becerra that your input and recommendations are vital to our budget formulation process. This consultation is intended to provide a venue for a two-way conversation between tribal leaders and HHS officials on programs, issues, and concern that will lead to recommendations not to sit on the shelf, but for action. Shortly, you are going to hear more from our partners and the Assistant Secretary for Financial Resources on the budget process and how your recommendations inform what the department actually does, but also want to quickly highlight and celebrate some budget wins, which sometimes is rare these days. These wins are, of course, a direct result of the recommendations and testimony that tribal leaders have provided over the years during previous tribal budget consultations. As you all know, late last year, Congress finally included advance appropriations in the FY 2023 budget spending package. This historic achievement is the result of years of dedicated advocacy by tribal leaders and has been a huge priority for Secretary Becerra since he was confirmed as Secretary in the spring of 2021. Not only was advance appropriations a priority of the Biden-Harris administration, but also for the Secretary personally. Since 2021, the Secretary made over 13 personal calls and outreach to senators and representatives on advance appropriations, and not to mention the countless other meetings that he did in person to be able to move the issue ahead. And that was the 1-2 punch of you also going to the Capitol Hill and also advocating to your members and letting them know the importance of advanced appropriations, because when there is a lack of a budget or agreement on spending, it should not lead to deaths in Indian country because IHS services are not available. And so next up is we want to continue to work together on mandatory appropriations. Tribal advocacy is going to be critical on this front, but the Secretary will continue to conduct personal outreach to his colleagues on the Hill to make sure that it's a reality. For today's and tomorrow's discussion, we look forward to hear from you all on what we need to be doing together to advance the continued budgetary needs of Indian country. We at HHS are committed to maintaining our nation-to-nation relationship with tribes and respect the core principles of self-determination. Next, I want to take a minute to speak to you about the format today. As I had mentioned, this is our first in-person tribal consultation since 2019, so we want to make sure that we provided an overview of HHS divisions, programs, and policies that impact Indian country. So consider that at HHS 101. So throughout today, you will hear from tribal liaisons and subject matter experts from across HHS and our divisions who will share with you information and answer your questions. You will also hear from our Assistant Secretary for Financial Resources, who can provide an update and overview of the HHS budget in 2024 and how tribal recommendations are taken into account for our budget formulation. After your discussion with our Assistant Secretary for Financial Resources, there will be a special swearing-in ceremony of the new Commissioner for the Administration for Native Americans. The Secretary will provide brief opening remarks for the ceremony. Afterwards, we will conclude our HHS overview. For those of you that have requested one-on-one meetings with our HHS division, this afternoon, those meetings will take place. And then tomorrow, we will start bright and early, 8:45 a.m., because the Secretary will be meeting with you all from 9 a.m. to 9:30 a.m. And the Secretary is eager to meet with you and hear from you what your budget and policy recommendations for FY 2025 are. And then throughout the day tomorrow, we will get a chance to meet with senior leaders at each division to engage in a thorough and thoughtful discussion about FY 2025 budget recommendations. Tomorrow, we'll conclude with the presentation of the HHS budget formulation work group's recommendations to the IHS leadership. Again, thank you for being here and look forward to today's and tomorrow's sessions. Councilman Joseph, if there are no questions, I would like to turn, well, let me ask questions first. I can't say there's no questions. I will look around and ask if there's any questions on what I just presented on. I was leading the witness, huh? Councilman Joseph, because there are no questions, I would like to turn it over to my colleague, Devin Delro, Acting Principal Advisor for Tribal Affairs, who will start with part one of our HHS overview, and he will help facilitate the rest of the updates from our federal participants. And before I do so, again, I want to thank you all for being here today. The Secretary always says if the tribal leaders are going to bring their leaders, we have to bring our leaders today to bear, and we have done that, and we'll continue to do so. And so thank you again for being here. We look forward to the conversation.
All right. Thank you, Marvin, and thank you, tribal leaders, for being here. As Marvin mentioned, my name is Devin Delro, Associate Director Acting Principal Advisor for Tribal Affairs in the Office of Intergovernmental and External Affairs here at HHS. I am also a member of the Navajo Nation. So just want to give you a quick overview of how this HHS 101 presentation was formed. As Marvin mentioned, our last in-person meeting was over 4 years ago. So we did have a series of planning calls with tribal leaders, with tribal representatives, subject matter experts, our colleagues at the National Indian Health Board, to develop the agenda for this year's budget consultation. And through that process, there was several requests to do a resource day, essentially, to have that 101, not only to refresh everyone's minds about HHS and the plethora of programs that HHS offers, but also to help inform some of those tribal leaders who might be new to their positions. So that's how this day was developed in the presentations that you will hear from our subject matter experts. So I just wanted to kind of set the stage for you before we get into the presentation. I know it's sometimes difficult to have these one-on-one classes early in the morning, so I appreciate your patience as we go through these presentations. After every operating division gives their brief remarks, there will be opportunity for tribal leaders to ask questions. All right. So HHS represents almost a quarter of all federal outlays, and it administers more grant dollars than all other federal agencies combined. HHS Medicare program is the nation's largest health insurer, handling more than 1 billion claims per year. Medicare and Medicaid together provide health care insurance for 1 in 4 Americans or 1 in 3 Americans, depending on the final enrollment numbers for the recently passed open enrollment. The department includes more than 300 programs covering a wide spectrum of activities. In addition to the services they deliver, the HHS programs provide for equitable treatment of beneficiaries nationwide, and they enable the collection of national health and other data. Examples include disease prevention, including immunization services, assuring food and drug safety, including Medicare, Medicaid, financial assistance and services for low-income families such as TANF, child abuse and domestic violence prevention, and comprehensive health services for Native Americans. The department's programs are administered by 11 operating divisions, including 8 agencies in the U.S. Public Health Service and 3 human services agencies. In addition to the services they deliver, the HHS programs provide for equitable treatment of beneficiaries nationwide, and they enable the collection of national health and other data. HHS also works closely with state and local governments as well as tribal governments in the Office of Intergovernmental and External Affairs. With many HHS-funded services are provided at the local level by tribal, state, or county agencies or throughout private sector grantees. So here is the organizational chart of HHS. The offices located near the margins are commonly referred to as staff divisions or staff divs, and they provide direct support to the secretary. Those in the middle are operating divisions or OpDivs, and they have a majority of the money for the funding opportunities, so you want to make sure that you develop a good working relationship with these divisions and their respective tribal liaisons, many of which who are here today. So here is the chart of the United States showing the regions within HHS. HHS has 10 divisions headed up by regional directors. The regions represent the secretary at the local level. If you have not already met your regional director at their annual consultation sessions, which are coming up this summer, we encourage you to attend those sessions and meet them. Many of our operating divisions also have a regional office presence referred to as regional administrators. Here's where the confusing part happens sometimes. Here you have an overlay of Region 10, of the 10 HHS regions, as well as the 12 IHS areas. As you can see, there is some overlap in many of the areas, so sometimes it can get a little confusing between 10 HHS regions and 12 IHS regions, but this is a good slide to help kind of set the stage and provide some good background information. Now let's go through some of the leadership at HHS. So Secretary Javier Becerra is the 25th HHS Secretary and the first Latino in the United States history to hold the office. Prior to coming to HHS, Secretary Becerra served 12 terms in the U.S. House of Representatives and as the Attorney General of California, where he actually led a coalition of states to help defend the Affordable Care Act, which we all know includes the Indian Health Care Improvement Act, the backbone legislation of the Indian healthcare system. Secretary Becerra is also a known champion of the Indian Child Welfare Act as well. So he has a lot of experience that he brought with him with working with Indian country in his role as secretary. And here's a list of Secretary Becerra's top priorities for HHS, which include ending and preventing another pandemic, reducing healthcare costs, expanding access to care, tackling healthcare disparities, and strengthening behavioral health. Senior leadership at HHS is provided in the Office of the Secretary, which includes the Deputy Secretary, the Chief of Staff, the immediate Office of the Secretary, and the Office of Intergovernmental and External Affairs, which is where the Tribal Affairs team sits. Deputy Secretary Andrea Palm is the Deputy Secretary and is responsible for overseeing the day-to-day operations in the department, making sure the department is operating at its max capacity, is responsive to requests. Prior to coming to HHS, she was the Secretary Designee of the Wisconsin Department of Health Services, and she has numerous policy and operational roles in the Obama-Biden administration, including Acting Assistant Secretary for Legislation, Counselor to the Secretary, and Chief of Staff. The Chief of Staff to Secretary Becerra is Sean McCluskey. His history includes he was the Chief Deputy Attorney General at the California Department of Justice, Chief of Staff and Healthcare Counsel to then Congressman Javier Becerra and the House Democratic Caucus. Now, within the immediate office of the Secretary, They are responsible for the operations and coordination of the work of the Secretary. It is composed of the Secretary's counselors, the Executive Secretariat, which handles correspondence, regulations, different policies that work its way through the department clearance process, as well as the White House liaison. And then you just heard from Marvin Figueroa, who is the Director of the Office of Intergovernmental and External Affairs. He leads the IEA office as well as the 10 HHS regions. Previous to that, he was the Deputy Secretary of Health and Human Resources for Virginia. And within IEA, there's a number of different teams that work with different stakeholders. We have a team that works with the governors, we have a team that works for the counties, and we have a team that works for the Tribal Affairs team, which I have the honor of currently leading. And it's through the work of IEA that we help coordinate engagement with Indian country. We help manage the HHS Tribal Consultation Policy, as well as the Secretary's Tribal Advisory Committee. And so this is another more information on what I just said about the Office of Tribal Affairs and the work that we do. And then we maintain a number of HHS work groups, which includes the Secretary Tribal Advisory Committee, which was established in 2010 and was one of the first cabinet-level Secretary's Tribal Advisory Committees. And I know we have a number of our STAC delegates here today, so I want to thank all of our STAC delegates for joining us today. The STAC meets on a quarterly basis. Our next in-person meeting will be in September, and that will be our annual STAC meeting in Indian country. There are also a number of other tribal advisory committees that sit at the different HHS operating divisions. And then every once in a while, work groups are convened that are comprised of tribal leadership as well as federal partners to help lead some of the work forward. In past instances, work groups help develop the HHS consultation policy and other different pilot projects. So this is just a brief listing of some of the operating divisions that you're going to hear from today. And next, I believe we have ACF. Oh, any questions for me before we move on to our next operating division? I know that was kind of a quick overview, and we will make sure that these slides are available to all those that registered digitally. All right, hearing none. Oh.
I got one, and I hope it's a simple one, but I do sit on a few of the advisory committees for some of the agencies, and I guess one thing I'd like to just mention, and I'll bring it up in other areas, especially the one-on-one, but sitting on the tax, tribal leaders take a lot of time to be a part of, and we form recommendations. And it's not hard, or it's not easy to get consensus. Some of the things that we have recommended on SAMHSA, as an example, it seems like those recommendations aren't getting elevated to the Hill. And so I just want to emphasize that when any of the advisory committees form recommendations, as we heard from Director Figueroa, we'd like HHS to help champion those as well with the agencies and referring those recommendations from the TAC. And I say that because I met with some Congress last year, and they had passed a bill, and the funding stream went through state block grants. And on SAMHSA, we've said we don't support state block grants because they decrease what comes to the tribes. And when I mentioned that to the Congress staff, they didn't even know that there was a tribal advisory committee in the agency. And so I had to re-educate them. And so I just want to emphasize that when we do this work, that the HHS help really get the recommendations from all of the TAC to those on the Hill so that it can help make a difference. It wasn't that we opposed the bill in itself, because anytime we can get resources to Indian country, we're supportive, but it is a barrier, and a lot of tribes struggle with those kind of funding mechanisms. So I just wanted to mention that. Thank you.
I appreciate that, that recommendation, and it's something that we're in process of looking how we can do better. I know we are also working to update our website. It hasn't been updated in quite a while, and what we'd like to do is have that serve as a one-stop shop, not only where folks can go to see TAC vacancies, but also summary meetings of, or summary notes from previous meetings, minutes, so folks can see what was discussed, see what some of the recommendations are, and be better informed about what's happening across the department with all these different advisory committees, as well as the recommendations from them. So absolutely appreciate that. Any other questions before we turn it over to ACF? Great, thank you.
All right. Good morning, everyone. Thank you for being here. Thank you for anybody who's watching online. Again, my name is Michelle Sauve. I am a member of the St. Regis Mohawk tribe, so thanks for whoever set the room up to put the two Haudenosaunee women together. That was nice. So I'm going to tell you a little bit about what we do at ACF. We are one of those 3 human service agencies that Devin talked about in the introduction. And so we are responsible for those federal programs that promote economic and social well-being for families, children, individuals, and communities. And so a little bit about how we do that work. Obviously, there's funding that goes out directly to states and tribes and local communities, but also strategic partnerships to promote policies and training and technical assistance. So a lot of the things that the other operating divisions do, ACF is doing as well. So one of the important things to note about ACF, if you took a look at that tribal crosscut for Native American funding, we are the second biggest operating division in HHS. There is a lot of funding that goes out to Indian country as part of the grant making that ACF does. And so I want to talk a little bit about the ACF leadership. It mirrors a little bit about what Devin said. We have an assistant secretary for ACF, January Contreras. She will be here tomorrow at 3 o'clock for the ACF portion of the tribal consultation. And these are the other appointed officials within ACF that are serving in the immediate office of the assistant secretary. ACF, I think, is a little bit unique. We have very many political appointees. These are the program office leaders. And within this, all the acronyms aren't spelled out for you, but there are only 2 folks on here that are not political appointees, and that is Natalie Grant. She leads the Office of Human Service, Emergency Preparedness and Response, and Director Catherine Choen, the Office of Trafficking in Person. Everybody else you see on here is new and part of the Biden-Harris administration and representing the various program offices within ACF. We also have some back office leadership. Devin talked about the staff divisions that support. These are some of the staff divisions that support ACF. And in particular, I want to talk to you about the 3 ladies on the right because our director of the Office of Legislative Affairs and Budget, those are the things that the legislative changes that you want ACF to put forward, the budget, that's Ms. Amanda Barlow. She will not be able to join tomorrow, but the Director of Budget, Michelle Patterson, will be here for the ACF session. We also have an Office of Planning, Research, and Evaluation, and that is the research and evaluation arm for ACF. And then our Director of Regional Operations is Carlos Williams. Devin showed you those great maps where we have regional offices, so Carlos is the Director for Regional Operations and works with all of the regional administrators across ACF. So HHS has 300 plus programs. ACF has 60 or more of those programs. And they're programs you're probably very familiar with, like Head Start, your child care funding. We also handle the refugee and resettlement assistance, the unaccompanied minors program. That often takes up a lot of ACF time, but we don't often talk about that here at the tribal consultation. We do talk about how things are going with the low-income heating the Home Energy Assistance Program, how things are going with TANF, with child welfare, and so on. So these are some of the programs, and I'm really excited that our Assistant Secretary has really taken the charge of the President to fulfill the nation-to-nation commitment to tribes. I didn't develop these slides, so people are listening to her. They're listening to the administration and putting it in here that we need to be mindful as we are operating our programs, that we are doing this in partnership with tribes. And so again, our Assistant Secretary has put forward 8 priorities for ACF for 2023. Again, one of them is fulfilling the nation-to-nation commitment to tribes, but also advancing opportunity for young adults, increasing child and family safety and well-being, building economic stability and mobility, supporting the human services workforce. We know there have been a lot of challenges, especially with the pandemic. We are having challenges filling those human service workforce needs, so that needs to be a priority right now. And strengthening early childhood sector for families, integrating mental health supports that mirrors one of the Secretary's priorities, right, to focus on mental and behavioral health. And finally, kind of an inward-looking focus goal of pursuing our own operational excellence. Although we are here to focus on the FY25 budget, I just wanted to give a baseline of where we are for this year. And so ACF's total budget is $75.2 billion. It's roughly split 50-50 between discretionary things that Congress can go up or down on and mandatory spending, which are, for example, are programs like TANF, the Temporary Assistance for Needy Families, or the Social Services Block Grant that are mandatory. So on the discretionary side, we have a little pie chart for you here so you can see sort of the breakdown of where ACF is spending the majority of its money. You can see in here that Head Start is one of the biggest programs on the discretionary side, but then also Child Care Development Grant and closely followed by the Unaccompanied Children Program. On the mandatory side, TANF is the big program in the room with $17.3 billion, and tribes are able to operate their own TANF program directly. And then you have the child care entitlement, foster care and permanency, and so on the mandatory side. Devin mentioned it's important to get to know the regional directors. This is really small, but you'll get copies of this. So it does list who the regional administrators are for ACF. We do encourage them to participate in those HHS regional consultations, and many of them participate in the quarterly tribal calls that are follow-ups to the HHS regional consultations, and they track the ACF issues, and they coordinate with us at headquarters so that we can work on issues throughout the year that you bring up in the regional consultations. And finally, you can't read this from the screen, but again, you'll have it. We do have a tribal advisory committee. Councilwoman Jenny Webster, who's sitting next to me, is one of the ACF TAC members. And we have had this TAC probably for about a decade, maybe. It's not quite as long as the Secretary's Tribal Advisory Committee, but it was started shortly thereafter. And so our TAC also meets on a in person at least 3 times a year, but they meet on the interim on a shorter basis because with so many program offices, so many programs, there's a lot to keep up with. So we really appreciate the time that the tribal leaders take engaging with ACF, with leadership, with our Assistant Secretary to raise issues. They're in the process of developing a very well thought out strategic plan and priorities for the TAC to engage with this administration. And so I think that's all I have. So I will take questions if there's any.
I have one question real quick. You said you were going to be here for the one-on-one later. Are you booked up for all the one-on-one? Because I would like to talk to you about some stuff.
Oh, no one has requested to meet with ACF, so if you would like to, we can figure out how to make that happen.
Thank you.
Thank you. Again, my name is Shay Welch. I want to thank all of the council members and the new individual in particular. Thank you so much for coming. You know, this is one of those pieces of, there's a lot of information. And just to absorb all of that information for myself, right, is difficult. So thank you, young man, for standing up and learning and being willing to travel to be here. And to all of those who are online, it's very important to see you as well. As I indicated, my name is Shay, and the CDC's mission is really about protecting 24/7, 24/7. And when I worked on the COVID response, it literally was 24/7. But COVID or not, we protect America's health, safety, and security threats, both foreign and in the U.S. Whether disease starts at home or abroad, they're chronic or acute, curable or preventable, human error or deliberate attack. CDC fights disease and supports communities and citizens to do the same. CDC increases the health security of our nation. As the nation's health protection agency, CDC saves lives and protects people from health threats. To accomplish our mission, CDC conducts critical science and provides health information that protects our nation against expensive and dangerous health threats and responds when these arise. Many of you might know that CDC is under a reorganization. We call it Moving Forward, because we have to move forward. Our focus primarily is in improvement areas of share scientific finding and data faster, enhance laboratory science and quality, translate science into practical, easy-to-understand policy, prioritize public health communications, develop a workforce prepared for future emergencies, and promote results-based partnerships. That includes with tribes. Now, our teeny tiny little boxes here represent our realignment, our moving forward. And on the bottom right side, you'll see a new center. And that new center has the longest name ever, the National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce. CDC is known for our acronyms, but we can't even say that acronym. But in that center, as the little red star there, you can see that our director is Dr. Dolphin. Many of you have met Dr. Dolphin at the STAC meeting or our CDC Tribal Advisory Committee. In the red box, that's me. The point here is that CDC is moving forward and elevating the work and engagement with tribes. Our Office of Tribal Affairs and Strategic Alliances mission is to affirm the government-to-government relationship between CDC and American Indians and Alaska Native tribes by advancing connections, providing expertise, and increasing resources to improve tribal communities' public health. OTASA focuses on activities that reflect the agency's role in helping to ensure, helping to ensure that American Indian, Alaska Native communities receive public health services that keep them safe and healthy. Now, these little boxes may show up a little differently on screen, and we try to use appropriate icons because just in communication with tribes is a nuance. How we bridge our scientific information into language that is helpful to tribes and actionable in tribal communities. One size does not fit all. But we lead the Office on Tribal Public Health Issues and Policies. We develop and disseminate tribal public health strategies, policies, programs, and system improvements. Enhance government-to-government relationships through policy and consultation with tribal nations, including through our TAC. And when our TAC makes recommendations, we look at those carefully and work together to try and implement those. We collaborate and coordinate with HHS and other agency tribal liaisons on HHS-wide tribal activities. We establish partnerships and provide technical assistance to CDC programs, which, if you saw that big organizational chart with all those little boxes, there's a lot. There's a lot of activity within CDC. So we provide technical assistance to CDC programs as well as external partners. We also support implementation of culturally responsive and traditional practices through evidence and practice-based models. Now I'm going to turn it over to CMS, and while I'm handing the clicker here, I'll entertain any questions that you might have. And we're not booked up either if you want to talk to us.
I don't have a question. I have a comment. Nate Tyler, Makah Tribe. I do sit on the CDC advisory committee. You know, we're probably one of the most traveled tribes in the lower 48. Washington State to Washington, D.C., Washington State to Atlanta. And I thought it was important to invite the director to Makah. I did offer her the invite. The invite still stands. I think it's important to see firsthand, you know, how we operate, how unique we are. But most tribes still have the same needs that need to be fulfilled and met. So just wanted to remind you on the offer to come visit Makah. But I do appreciate it.
Thank you, Councilman Tyler. It is important to get to Indian country. And while we all share some commonalities, each individual community is very different. And we are working on looking at the 10 regional consultations that are coming up and how we can get our principles, our leadership out into Indian country, be it rural, remote, or frontier. Those are three very different things. But thank you again for the reiteration of the open invitation.
A question, and wanted to follow up on Nate, and I think it's more of an open one as well on this portion. You know, when the Secretary of HHS was first confirmed years ago, one of his first visits was to Seattle, and I remember being at that meeting with Andy, and Nate were there, and so it really, to me, started off this administration and all the agencies under it in a good foot, getting out to Indian country. I know I see the director of IHS, one of her goals was to visit all 12 areas within the first year of her being in office, and she continues to do that today. And I brought up with the VA secretary, I know that's a little bit separate, but trying to challenge all of our federal partners to get out to Indian country, because I don't see that from a lot of our federal partners. And one of the things that I know I'm very passionate about is addressing the fentanyl issue that is robbing us of a generation. And I know we do have a lot of invites out to different federal partners for the National Fentanyl Summit that will be in Washington State later this year in August. And you know, I'm looking, and I try to just Google anything with any of the agencies that are presenting. And you know, for the CDC, one of the things that has come out recently is the CDC is saying the overdose rates are decreasing due due to the fentanyl issues, and it's in the online. But I would say maybe that's true on an overall national scale, but you come out to Indian country, that's not the case. We're having to, unfortunately, have funerals every week in our community. If you Google our local newspaper, one of the things that we had recently that just became public is another child died. We had a 5-year-old die of a fentanyl overdose. Not too long ago, we had a 3-month-old die of a fentanyl overdose. You're starting to see those stories trickle up more. And so when you see reports like that from agencies that are saying the fentanyl death rates are decreasing, to me that's concerning, because we're missing a big part of the story, of our reality. And I think that's why it's more important to get out to Indian country and meet with the tribes. And I would say for any of our agencies here, you have an open invite to the Northwest. As the chair of the Portland area, we will extend an invite to any one of you that want to come out to any of our 43 tribes in the Northwest. It is very different from some of the areas from the east side to the west side, and we'd love to show each and every one of you our stories. It makes it more personal, and when we see that we're normalizing going to funerals more than birthday parties, that is telling me that we're growing up with trauma and we're accepting it. And that's not our way, and we need to do a lot more. And so I challenge every federal agency staff member, if you're in a position of leadership, take the tribe's offer to go out to the communities, because when we see, like I said, reports like this, it's telling that it's not important. And that's something we can't stand for. So I want to push back on things like that, and wanted to say I want to see more of the studies that highlight our reality, because that's what the people here on the Hill see, is they could, that's not as big of an issue, it's decreasing, everything's working. That's not the case, not in Indian country. So I just wanted to make those comments, and I know I'm asking our staff because I've heard there might be a few one-on-one open vacancies, so I'm asking my staff for that. So hopefully I can squeeze some in at the last minute with some of you. Thank you.
Thank you, sir. Every word you said is true. The challenge is the data. And we are working on the data modernization initiative within CDC. It's very infant. But as you said, when we look at the overall country, but here we need to look at the tribal world. Within Blackfeet, I can only speak for my own. We've lost so many to fentanyl. Pick an opioid. Doesn't matter what it is. We are losing our culture, our traditions, our norms, and we are becoming more routine on going to funerals than the birthday parties or the softball or our basketball. And that is why CDC is partnering with other HHS entities such as SAMHSA and ACF and et cetera, because we can't do it alone. And we also need our tribes. We can't say what the answer is, but together we may be able to come up with at least a platform to begin to do this. It's much like when our trees and the leaves start to brown and limbs start to die, and we look at the tree and we think, what is happening? And we have to get to the root cause. It's down in the roots. And how do we address that? But if we are going to put reports out, as we do, that are based in science and data, then we have to get the data right. Some of the challenges, as you know, sir, and people in this room, and I know Chairman Joseph, I'm out of time, but if you'll just allow me one more moment, that in a number of states, CDC does not collect data. Data comes to us from states, and some states don't even count race or ethnicity, let alone tribal level data. So partnering with IHS, but IHS only collects so much data as well, whether it's a direct service tribe, et cetera, right? So again, we have to look at that root. What's the root of our data and the misclassification of our peoples? But it's not lost on us, sir. And we ask for your cooperation, your collaboration, and assisting us, all of us, the whole of government, in addressing this crisis, yet another crisis in Indian country. So thank you for that. And Chairman, thank you for allowing me the additional moment.
I know we all have, I know it's really close to our hearts, a lot of the issues that come up, and we do have opportunities for one-on-ones, and then also each department will be presenting, I believe, tomorrow, so we can have more interaction then. We'll move forward with the agenda. Go ahead.
Thank you so much. I'm Beverly Lofton, and again, I work in the Division of Tribal Affairs at CMS, to all the folks who are online or in the room. And I'm here with the fearless leader, Kitty Marks, who leads the division in all of our efforts. So in our office, here we go. Just to talk a little bit about the role of CMS Tribal Affairs. In our office, the Division of Tribal Affairs, also called DTA, we are part of CMS. Specifically, we're located in the Children and Adults Health Programs Group, and that is within the Center for Medicaid and CHIP Services. A list of DTA staff in NACS, which is also called Native American Contacts, are posted on our website, and I'll give you information about our website later in the presentation. Even though we're located within Medicaid, we still work on all tribal issues that come up at CMS. So for example, we work closely with our partners in Medicare, the Survey and Certification, the Marketplace, Data and Information Technology offices, and the Office of Minority Health. This slide shows some of the history of Indian Health and CMS programs. We want to highlight that the ability for ITUs to bill CMS is unique. This was intended to increase funding streams for Medicare and Medicaid for Indian Health programs, not to offset the funding to IHS. So this funding is to increase health money for those programs. The ability to bill CMS has increased reimbursements to the Indian health system to over $1 billion a year. Reimbursement increases as more people enroll in Medicaid and Medicare. So that brings more funding to the Indian healthcare system to meet accreditation standards, buy necessary equipment like MRI machines, and also recruit additional staff that's much needed. The Children's Health Insurance Program, Medicare, and the Marketplace programs are all part of CMS. So IHS, tribes, and urban Indian organizations all have the ability to build these programs and increase their revenues. Medicaid is a joint federal state program. For services provided to American Indians and Alaska Natives, the federal government provides 100% full funding to states, which we call the Federal Medical Assistance Percentage, or FMAP. But remember, this funding goes directly to states, not to IHS and tribes. By Congress allowing the federal government to provide 100% of FMAP and fully fund care provided to American Indians and Alaska Natives, it helps fulfill the federal government responsibility to provide health care to tribes. Some about tribal consultation. So consultation is a critical part of addressing the unique needs of American Indians and Alaska Natives in our Indian healthcare delivery system. And CMS is committed to tribal consultation and working on policy issues impacting tribal communities and Indian healthcare providers. We consult through formal face-to-face meetings, all tribes calls, Dear Tribal Leader letters, and also as we receive comments through part of the rulemaking process. It's really important to participate in that rulemaking process. CMS is the only federal agency with tribal consultation that's also at the state level. States with Indian healthcare providers are required to have tribal consultation plans in their Medicaid state plans. So for more information, visit our state tribal relations page. You may have heard, I'm going to go back one side. Sorry, you may have heard that on January 26, 2021, President Biden issued a White House memorandum on tribal consultation and strengthening nation-to-nation relationships, reaffirming the government's commitment to tribal sovereignty and self-governance, to fulfilling federal trust and treaty responsibilities to tribal nations, and to ensuring regular, meaningful, and robust consultation to tribes. The agency is now in the process of updating its tribal consultation plan and updating that policy as well. The Tribal Technical Advisory Group, or TTAG, provides advice and expertise on tribal issues facing CMS. We do a lot of our TTAG work through subcommittees, and those subcommittees are committees such as policy, outreach and education, data, long-term services, also behavioral health, and strategic planning. TTAG consists of 12 representatives from each of the 12 IHS areas and a representative from each of the following tribal organizations: the National Indian Health Board, National Congress of American Indians, National Council on Urban Indian Health, Tribal Self-Governance Advisory Committee, and also the Indian Health Services. So we want to thank all the tribal members from those various areas and thank the TTAG for all of that hard work that you put in. We appreciate it. These are some of the special protections for American Indians enrolled in Medicaid. These special protections are often referred to as ARA protections because they are a result of the American Recovery and Reinvestment Act of 2009. As you see here, Indians enrolled in Medicaid or CHIP do not have to pay premiums or enrollment fees. And if they received care from an Indian health care provider or through an ITU referral to a non-Indian provider, they still do not pay any cost sharing such as deductibles, coinsurance, or copays. Income determinations for Medicaid and CHIP are different from the marketplace. In Medicaid and CHIP, certain types of Indian health income resources are not counted when determining Medicaid eligibility. This slide lists the type of income that is not counted in Medicaid. Payment received from tribe or individual payments from natural resources, farming, fishing, ranching, rents, or other monies from lands designated as Indian land by the Department of Interior are not counted when determining Medicaid eligibility. This includes within the boundaries or most recent former boundaries of a reservation and monies for cultural and traditional activities or items. Again, these monies are not counted when determining Medicaid or CHIP eligibility. There is one exception. However, any income derived from gaming does count when determining Medicaid income eligibility. Keep in mind that the rules for determining income eligibility are different in Medicaid and CHIP than they are for the marketplace. For example, if you report income from traditional jewelry you sell when you file your federal tax returns, then you must report it when determining income eligibility for the marketplace. However, if that jewelry has cultural significance, you do not have to report the income from the sale of the jewelry for Medicaid purposes. The Division of Tribal Affairs has a great fact sheet on our website that explains all income exclusions in detail, and that is called MyJai and Indian Trust Income. So I'll move over to the marketplace. So as I mentioned, eligibility for eligibility for Medicaid, this is one of the most important protections for Indian eligibility. And again, remember, it's different on the marketplace than it is for Medicaid and CHIP. For the marketplace, the general rule is if you report something on your income tax return, you then report it for marketplace purposes. We have a brochure called Understanding Cost-Sharing Protections that explains the cost-sharing protections on the marketplace in more detail. And you can find that fact sheet also on our website, and I'll give you that information at the end. Keep in mind that tribal members are responsible for their share of the premiums after application of the advanced premium tax credits. So the next few slides, I'll just cover Medicare, or maybe just one slide that covers a few things about Medicare and enrollment and disenrollment. So Medicare annual enrollment period, what we refer to as AEP, is October 15th through December 7th each year, often referred to as Medicare open enrollment. During Medicare open enrollment, Medicare beneficiaries may enroll or disenroll in Medicare Part C, which includes Medicare managed care plans, and we also call that Medicare Advantage plans, or MA. During the Medicare open enrollment, MA plan enrollees may enroll in another MA plan, disenroll, or return to original Medicare. The special open enrollment for MA plan runs from January 1st through March 31st. During the MA open enrollment, individuals already enrolled in an MA plan can add or drop a Part D coverage, and individuals enrolled in a MA Part D plan or MA only plan can switch to one of the following: an MA Part D plan, an MA only plan, or original Medicare. Almost done. Okay, so I'll move to our fact sheets. I'll jump to that. So the Division of Tribal Affairs has lots of fact sheets and brochures. These are examples of the latest brochures that we have and that cover information on Indian health facilities and in your state. Several years ago, we did hold focus groups to test materials and found that utilizing graphics and pictures in tribal tribal beneficiaries or communities increase the likelihood that people will pick up the brochures in clinics. So we want to make sure that people are picking up these brochures when we have them out, and also during outreach activities. Our materials are developed to be culturally appropriate and utilized in tribal communities. If you find any errors in our material, please let us know. All materials are available for download on our website, or you can order it from our website. So I'll go to our next slide. I know we're running out of time. So we recently developed a calendar that is an 18-month calendar, covers June 23rd through January 2025. Oh, sorry. So we have an 18-month calendar. We just updated it, and you can order that. It features website links and other helpful tips to improve overall health care. So our information on our calendar is intended to assist tribal families in taking better care of the family and communities. The calendar is available to order through our website. Are we out of time? Okay. So DTA produces public service announcements, and we use two platforms for those monthly messaging, and that is newspaper and radio ads. We found that radio ads it still really is helpful and is an effective means of reaching tribal populations. And we received feedback that it is effective also for PSAs to use them in other languages. So we started recording those in native languages as well. So we have 10 different languages that we offer, and you'll see those 10 languages there. So, and as you see, there's 10 languages there. So if you have any questions, that's the end of the CMS presentation.
Okay, we have the hard stop now, so
Yes.
we'll move on with the purpose of this session is designed for the Office of Budget and the Office of Assistant Secretary for Financial Resources to give a brief overview of the HHS budget, current updates and on the budget process, and an overview of the current budget situation. I'd like to introduce Robert Gordon, Assistant Secretary, and Taylor Anderson, Senior Program Analysis, HHS Office of Budget.
Good morning, everyone. My name is Robert Gordon. I'm the Assistant Secretary for Financial Resources at HHS. That means I'm the Chief Financial Officer and the lead for the budget. It was my privilege during the Obama administration to work on tribal issues and with some of you, and I've also very much enjoyed the chance to work with the stack in this administration. We very much appreciate and value the centrality of tribal consultation throughout the budget process. This morning's conversation will have three parts. First, I'm going to turn over to my colleague Tyler Anderson, who's going to provide an overview on budget and appropriations process, which is something that was requested for this year. Next, I'm going to provide an overview of this administration's budget proposal for the fiscal year 2024. And finally, we'll do some Q&A, and happy to have a conversation at that juncture. I will also be at the conversation with the Secretary tomorrow and enjoy the chance to hear your questions and engagement there. So without further ado, I will turn it over to Tyler.
Thank you. All right, can everyone hear me? Great. Morning, everyone. As Robert noted, I'm going to start by doing an overview of the budget process, both from the executive branch perspective and also talk a little bit about the congressional process. And during this part, I'll talk about the Office of the Assistant Secretary for Financial Resources, or ASFR. I'll give an overview of the current HHS budget, including talking about some targeted funding to American Indians and Alaska Natives, and would point out that at the registration table, you should have received a tribal funding crosscut, which goes over all of the tribal funding at HHS for fiscal years 2022 through 2024. So that should be a helpful reference. And then I'll talk, as I said, about the federal budget formulation process and close with some challenges and opportunities in that process. We'll do my best to manage this clicker. There we go. So ASFR is the office within HHS that coordinates on the areas of grants, budget, finance, and acquisition. And we'll be talking largely about budget today, but I just want to acknowledge the breadth of work that takes place within ASFR. The Office of Budget, which is where I work, leads the department's budget formulation and execution activities and plays a key role in the annual HHS tribal budget consultation process with our partners in IEA. The Office of Budget provides direction and implementation of budget activities across the department. So we provide guidance to all the operating divisions about the budget process, and then we work through the summer with the Secretary and HHS leadership team to facilitate budget decision-making, and then we work with the Office of Management and Budget to negotiate and come to final agreement on budget policies. Throughout all these processes, we consider tribal priorities and feedback that we receive from you all through these formal consultations as well as informal engagements that we have with you throughout the year. And we coordinate directly with agencies across the department to advise them and to give them guidance on how they should incorporate tribal priorities as well. So this session is really invaluable for us to receive direct feedback from you and input about your priorities for the budget each fiscal year. So on this slide, you can just see kind of a breakdown and overview of the HHS budget. The fiscal year 2024 President's budget proposes $1.7 trillion in outlays for HHS. And another way to think of outlays is just how much money will be spent on HHS programs. So the HHS budget is massive. I think we are the largest non-defense discretionary budget across the federal government. If that's wrong, Robert should correct me. The largest portion of the HHS budget is mandatory spending through Medicare and Medicaid, which our CMS colleagues just talked about. And then discretionary spending, which is kind of the spending for all of the other optives and stafftives, makes up a much smaller portion of the HHS budget at around 9%. I'm going to talk a little bit more about the difference between mandatory and discretionary funding for those who might be less familiar. So many agencies within HHS receive both mandatory and discretionary funding, and the distinction between the two is an important one. So mandatory funding, or sometimes it'll be referred to as direct spending, is spending for entitlement programs or other payments that are authorized and required by law. Mandatory spending is generally governed by statutory criteria, so it's not subject to the annual appropriations process. So when, for example, if there's a continuing resolution or a government shutdown, most mandatory funding is not impacted by that. Examples of mandatory funding within HHS include Medicare and Medicaid, the Children's Health Insurance Program, or CHIP, the TANF program at ACF, and the Special Diabetes Program for Indians at IHS. Discretionary funding, on the other hand, is subject to an annual appropriations process, so Congress has to approve it every year. And as you probably know, that process doesn't always go to plan, or often doesn't go to plan. But it does account for a large amount of funding here at HHS and the agencies that you may be familiar with, such as SAMHSA, CDC, NIH, HRSA, and IHS. So this slide shows a breakdown of targeted funding to American Indians and Alaska Natives at HHS, and this is from the FY 2023 enacted appropriation. So in FY 2023, which is the fiscal year we're currently in, HHS has around $9.3 billion of discretionary funding that's targeted to tribal programs. The large bulk of that, about 75%, is, of course, the Indian Health Service. But there are other programs across ACL, ACF, SAMHSA, et cetera, that are also targeted to tribes. And so we use the tribal funding crosscut to track this, and we hope it's a helpful resource for you too in identifying which resources may be available to you all. Some of these programs outside IHS, just for some examples, is like the SAMHSA Tribal Opioid Response Grants, CDC's Good Health and Wellness in Indian Country program, and ACF has a number of tribal programs within their larger programs, so TANF, Head Start, et cetera. Over time, HHS funding for tribes has continued to grow. However, as I noted, the largest portion of that has been due to growth in the IHS budget overall in recent years. So now I'm going to pivot to talking a little bit about how HHS creates the budget requests each year. On this slide, you can see that we're always working kind of across 3 fiscal years at the same time. So I'm going to go from top to bottom and talk about each one. So the orange box that you see is the current fiscal year that we're in. We're currently in fiscal year 2023. Congress provided appropriations for fiscal year 2023 back in December. So we've completed most of the budget execution steps needed to issue FY 2023 funds, and agencies should be getting those out the door and completing that through the end of this fiscal year, which ends on September 30th. So the orange box on top is kind of like the you are here X, that's where we are right now, and is the only kind of fiscal year in which we have current money to spend. Moving down to the green box for fiscal year 2024, as you may have seen, the President recently released his fiscal year 2024 budget request to Congress back in March. And so now Congress is working to evaluate the request, and then Congress must take action to provide appropriations for fiscal year 2024 before the end of this fiscal year. If Congress does not take action to provide appropriations before that time, then we will either face a government shutdown, or the maybe likelier scenario would be a continuing resolution to continue funding at current levels. And then lastly, the blue box notes fiscal year 2025, which is the purpose of the meeting today and tomorrow. So we are also beginning formulation for the fiscal year 2025 President's budget. ASFR actually recently last week released our guidance to agencies so that they can start working on their requests to the department. And then we will go through a process, which I'll talk a little bit more about, and the fiscal year 2024 President's budget, fiscal year 2025 President's budget, in theory, will be released in February of 2024. And as you can see, I never know which fiscal year I'm in, so apologies for that. So now I'm going to talk a little bit more about the internal HHS budget process. You can see on the slide, there is a timeline up here, and the budget process is a year-round effort. And I do want to acknowledge that even before HHS starts our budget process, IHS and their tribal budget formulation work group start their budget formulation process even earlier. So I believe back in September, the IHS budget formulation work group began meeting around the fiscal year 2025 budget in order to be able to present their recommendations at this meeting that we're at now. So basically, right after the President's budget is released each year, we start working on the next year's President's budget. In the spring, HHS holds its annual budget consultation with tribes, which is our first kind of big formal engagement around the FY 2025 budget in this case. Around that same time, ASFR will issue department-wide budget guidance to agencies. This guidance will lay out, for example, what funding targets the agency should hit, so usually like a percentage above or below the prior year's budget. It will also lay out priorities for HHS leadership, including the ASFR and the secretary or deputy secretary, and other technical information requests for the budget submissions. Then in late May, the agencies will submit their budget justifications to HHS. Their justifications should include budget information along with recommended legislative changes. And this is also when IHS formally provides their tribal budget formulation work group recommendation to HHS. And then that kind of kicks off a process that takes place throughout the summer where HHS leadership reviews and evaluates the submissions, and the Office of the Assistant Secretary for Financial Resources facilitates what we call the Secretary's Budget Council meetings, where we meet with the Deputy Secretary and other HHS leadership to provide recommendations and seek their guidance about the Secretary's budget request. And then later in the summer, the Secretary will make final decisions, which are provided back to agencies. Agencies have an opportunity to appeal those decisions, and then we reach what we would call final settlement, which is where we've reached agreement about the budget policy that we will submit to OMB. So that is the HHS portion of the budget process, right? Then the budget travels outside of HHS and it goes to the Office of Management and Budget, which is the budget office for the White House, essentially. So we submit the HHS budget request to OMB typically in September, and that is when OMB receives submissions from across the federal government. And then throughout the fall, OMB will review the submissions, and they'll also meet with agencies to examine the details of the proposals and evaluate the proposals across other government-wide priorities. Each agency's leadership would typically formally present the recommendations to OMB. And last year, we also implemented what I hope will be a new recurring kind of engagement with OMB, where the IHS Tribal Budget Formulation Work Group met with them directly to present the tribal budget recommendations as well. And then by early winter, HHS and OMB will be negotiating the budget policy through a process that we would call pass back, where OMB passes back their decisions to us, and then we go back and forth for a bit to negotiate what will ultimately be in the President's budget for HHS. And then once that decision is made, then we work over the next couple of months to produce the budget, write the materials, make sure everything's ready to kind of roll out in the spring. So as I said, the President's budget is rolled out typically the first Monday in February, although I would say that is a goal and not always when it actually happens. In the last couple of years, the budget has been released later in March or even as late as May during the presidential transition year. The budget rollout is the first time that the budget becomes public. Prior to that, all of this kind of process and decision-making that I talked about is internal to HHS and OMB. The budget includes discretionary and mandatory funding proposals, as well as legislative proposals and other policy changes, and it really is the executive branch's kind of overarching policy proposal to Congress about how the government should be funded in the next fiscal year. The release of the president's budget also kicks off the annual congressional appropriations process, and the next step after the budget is released is for Congress to consider the proposal and decide whether to enact all or some or none of it. But either way, they have to enact funding for the next fiscal year, and the budget release kind of kicks off that process. So now I'm going to talk about the congressional side of the budget process. This slide provides an overview of the different types of congressional committees. So there's various congressional committees with different jurisdiction that impact enactment of the budget each year. The most important for the purposes of discretionary funding would be the Appropriations Committee. So the Appropriations Committees are responsible for enacting discretionary funding each year. And there's an overarching Appropriations Committee and then subcommittees. Labor, Health and Human Services Subcommittee is the main appropriations bill for HHS, so it provides the majority of HHS discretionary funding. However, IHS is funded out of the Interior, Environment, and Related Agencies Appropriations Subcommittee, and the Food and Drug Administration is funded out of the Agriculture Subcommittee. So there is a little bit of HHS money outside of Labor HHS. Authorizing committees review the budget for legislative proposals that can be enacted through an authorization act, but they don't take action on the discretionary parts of the budget request. Authorizing committees also consider any major mandatory funding proposals that would require legislative changes to be enacted. Authorizing committees have jurisdiction over authorizations acts, which are laws that establish or continue federal agencies or programs, and also establish or continue federal funding in some cases. And then the last kind of committee with jurisdiction here is the Budget Committee. The Budget Committees influence budgetary priorities and draft budget resolutions, although a budget resolution is not legally binding and it does not actually provide funding. So budget resolutions don't always get passed every year. I think you've maybe seen in the news recently, budget resolutions have become fairly relevant in conversations around the debt ceiling and different ways to address that issue, but the budget resolution doesn't have a ton of influence on the discretionary appropriations process. So this slide shows a timeline for the congressional budget process. As I noted earlier, when the budget is released, in theory in February, this kicks off the congressional process. Congress will hold hearings. Typically, the HHS secretary or designated leadership will testify to talk about what's in the budget request and to answer questions about it. And then congressional appropriations staff will also work with staff at HHS, both in our office and at the agencies, to understand technical aspects of the budget request and to ask questions about it to inform how they move forward with the appropriations process. In May through July, the appropriations committees typically work to actually draft funding legislation. They'll do what's called markups, so they'll meet in their committees and introduce language, and then they'll do markups to make like amendments or changes to that language. They'll vote the bill out of committees, and then in theory it would be voted on the floor. Again, this doesn't always happen the way that it's written now, but this is kind of the regular process. By September, Congress should agree on a joint bill to provide annual funding to HHS before the start of the next fiscal year, which begins each year on October 1st. The process of negotiation between the House and Senate is also called conference, and it's usually a process that's fairly closed door, so it's not something that there's always a ton of visibility into, but they will basically negotiate until they can reach agreement on a bill that will pass in both chambers. And in theory, that could pass in both chambers before the start of a fiscal year. However, as you know, that rarely happens, and usually Congress will enact a continuing resolution which provides a portion of the year's funding while they make decisions on full year funding levels. So to close, I'm going to talk about a few challenges and opportunities for tribes to consider when engaging in the federal budget process. As I've noted a couple of times, while this process is supposed to happen one way on paper, we acknowledge that it often does not happen that way and often deviates from expected timelines. And especially as Congress has become more partisan, we've seen that the appropriations process rarely goes according to plan. We know and have seen that agencies operating under continuing resolutions can be challenging. And while there is a process where we can request additional funding through what we would call an anomaly, which would provide funding above the CR level, those are fairly restricted and rare. And so we understand that, operating at a flat level of funding is not always the best way to operate. If Congress does not pass the funding bill on time or pass a continuing resolution, there's also a possibility of a lapse in appropriations or a government shutdown. And we recognize and acknowledge that government shutdowns in particular have unique impacts on tribes and have had really devastating impacts in the past. As Marvin noted at the beginning, we were really glad that in the fiscal year 2023 enacted appropriation, Congress did include advanced appropriations for IHS. Services and facilities accounts, which will go a long way in addressing challenges both under CRs and if we were to face a government shutdown. But we acknowledge that beyond IHS, there are impacts in Indian country under either a CR or a government shutdown that can be extremely challenging. So lastly, I'll talk about a few opportunities and best practices that you all can consider when you're engaging with HHS or other federal agencies or with Congress throughout the budget process. When you're making recommendations, it's helpful to include data to the extent that it's available to demonstrate, how a program is effective or why, what issue is being addressed through the recommendation. This information is really valuable to us internally when we're formulating the budget. HHS leadership is very interested in having a budget that's driven by data. So to the extent that your recommendations can include that data, that's very helpful to us. We also recommend, if you can, identifying whether your recommendation is a budget or a legislative priority or an administrative fix. And this just helps us make sure we're addressing it in the right way in the budget. So is it an issue that requires additional funding to address? Or is it an issue that just requires a change in law and that would address the issue? Or is it something that the administration can do internally without even needing a legislative fix, in which case that's helpful for us to know. We also recommend thinking strategically about how best to address a budget issue. So there's a lot of different ways that a funding line or program can be structured. For example, you could recommend a set aside for tribes within a larger program. In other cases, it might make sense to recommend a fully separate program that's just for tribes and isn't a set aside within a larger program. But the more specific the recommendation is, the better, and it helps us really make sure that we can analyze it and apply it in our budget formulation process. So that concludes my portion. In your handout, there's some links as well that might be helpful information for you. I'm happy to answer any questions about the budget process itself, and then I'll turn it back to Robert. He's going to give a budget update for the fiscal year 2024 budget.
Okay. Jennifer.
Taylor, I'm here on behalf of the Bemidji area. So how would and where should we advocate to bring the whole level of the Bemidji area up? We've been the lowest funded of all the areas since the beginning, for all time. So where do we advocate to bring that whole level up for Bemidji?
Yeah, that's a good question. I think, to the extent that you can include area-specific recommendations in your written comments for this consultation, that's helpful. We take all of those back and we read through them all. I think we typically receive, kind of a standard set of recommendations that are driven by what the Tribal Budget Formulation Work Group recommends, but we're also open to specific, like if there's a geographically specific issue that we should be aware of. And then, of course, always advocating to your members of Congress is helpful because they have like a specific, they're driven to serve you, right? You elect them and they want to make sure that you all are happy. So that would be another thing. I think in our internal processes, we don't always make decisions in like a geographically specific way, right? Like we're looking at the IHS budget overall versus, each area. But it's helpful to have that feedback because we can think about, what are ways we can propose this to address it in the budget. So hopefully that's helpful.
Go ahead.
I'm Terry Parton, president for the Wichita Affiliated Tribes in Oklahoma. I'm here I came to this budget formulation for meeting for three reasons. And one was just to advocate for more funding for our elder programs. I said at our STAC meeting last time is we always talk about how elders are so important to us and stuff, but yet our funding for our program, we get like $114,000, and that's supposed to provide salaries, meals, transportation, and all that. So I'm here for that reason this week. But I'm also here I have a lot of tribal members that have passed away from cancer. And I've just noticed that I can tell you many of my tribal member women that have lost breast because of cancer. I just had an elder that died from colon cancer. A man the week before last, I went to his funeral, and he had just gotten married and been married a month, and found out he had cancer and passed away. And so you were talking about data, and one other reason I'm here is dementia. We have, in the last few years, have just noticed a lot of our tribal members have had dementia, and I've had a list of all of our tribal members and what they've passed away from, and so you were talking about data. So across all of the HHS program or agencies, like she was asking, where do you advocate for programs like that? Because I know with cancer, I know the Cancer Moonshot and IHS is working on that right now, but where do we get the data from the other programs that are here so that we can help advocate for more funding to address those issues, prevention for cancer and more earlier detection and dementia? I had a tribal member that struggled with her dad because nobody could diagnose him with dementia. Every time he'd go in to the doctor, he seemed fine, but he needed to be diagnosed. And I have a lot of tribal members that are suffering from that now. And so how do we get the data across Indian country on our people that are suffering from those? What agencies do we ask to help advocate for that? Thank you.
I don't know if you have thoughts on that, Robert. I know you're very interested in data-driven.
Yeah, so appreciate the comments. I mean, we are advocating, just so you know, and I'll talk more about this, for additional funding, both for people experiencing cancer as part of the Cancer Moonshot with a specific focus on Indian country, and also to support families where family members are struggling with dementia, which of course is something that most families experience at some point. And so we are advocating for that in our budget. And I think, ultimately it's Congress that decides how much money things get. So we've asked for this funding, but, candidly, we've asked for huge increases. And it's given just the situation in Congress right now, we're not likely to get all those increases. And so there is a conversation to be had with Congress about that. In terms of the use of data, I think we are super interested in that and want to support as much as we possibly can. I think, in general, the Indian Health Service is the best first place to go within the department for health challenges and experiences in the Indian country, but not the only place. Please go ahead. Sure.
And I'm thankful for Indian Health Services and stuff, but I can tell you that my tribal members that I have spoken to, either Indian Health Services did not offer the diagnosis and prevention testing, and they were diagnosed way late in stage 3 and stage 4. My aunt currently is suffering from cancer, and she had to leave IHS to go and get her treatment. And so there's not enough prevention that's going on. And I can tell you right now, I have insurance, I have 100%. I go to IHS, I can get my referral easy. But if I don't have insurance, my tribal members, a lot of them don't have insurance. If they go to IHS, they don't get those preventative testing, like a MRI or a breast scan or whatever, mammogram. They don't get those things because they don't have any other resources. And so they get put off and put off and put off until it's too late. So how do we advocate for more funding for preventative services and more testing so that it gets caught earlier so that they can get the treatment that they need?
Yeah.
And I know IHS is an HHS agency, and like I said, they do well in some things, but they do not do well in that area.
Yeah. I hear you, and I wish the best to your family members. And I think the near term with IHS is we're asking for a lot more funding. It's maybe a good point for me to start talking a little bit about what we've requested in our budget. But we've asked in this year's budget for about a $2.5 billion increase in funding for IHS, and a huge chunk of that increase is for services and would be to increase the level of services that are available on the front line to people who are coming in and saying, we need treatment, we need prevention, we need screenings, and it's more money to support exactly that. So we are advocating for that. I think there is a role for people in this room and others to advocate for that as well. I think I'm going to now just jump into talking a little bit about this administration's budget request. Did you want to?
Nick.
Yeah, I had a question, and I appreciate the comment earlier. You look at the $1.7 trillion budget for HHS. That's a large budget. And as I mentioned earlier, I do sit on a few different HHS advisory committees, and we've been asking for specific tribal set-asides, example. Even at a 2% set-aside, that's $342.5 billion. You look at the discretionary budget, that is 127.3. I get maybe outside of the discretionary, there might be some challenges in moving funding, but when you hear priorities like this, HHS does have discretionary, and to me that tells me that the secretary and the federal agency leads have the authority to move some of the funds around, and I'd like to start seeing more justification why we're not doing that. As I mentioned, I sit, and I'm coming to D.C., it feels like every month. It feels like I'm here more than I am at home. And then I'll say as a tribal leader, I get tired of coming to meetings and not getting answers. I'm sacrificing time away from my kids, my family, everybody else. So it's not a trip that I want to come on just for pictures and to sit at the table. I want to start seeing more results. And when tribal leaders are making those requests, I'd like to start seeing more justifications, either why or why not we can do those things. I know in some of them we've asked for 5% set aside, and there are some agencies that have worked on implementing a set aside, but it seems like not all the agencies are doing that. And so I'd like to hear more from your, I would imagine it's your office that could help with some of those discussions. And then on the earlier comment, we talked about the upcoming budget process. And one of the things that I have a lot of concern about, and I know the agencies, the organizations and the tribes that I work with, we see the politics here in D.C. We know what's going on, a lot of the debt ceiling limit discussions, and the talk about CRs. CRs kill our people. There's no funding increases in CRs. But even on this last budget for IHS, we got a $360 million increase through advanced appropriations. And, maybe a CR is like, okay, well, maybe we're going to keep that 360 in the event of a CR. But what's concerning is you're hearing discussions about rolling back to 2022 levels. And so we would lose the progress that we've made. And I'm wondering if you have any input or thoughts. And I know it's a guessing game. It's outside of our control, but if there's anything that you can help us with as the agency, this is for our people's lives that we're here advocating for, and so we can't afford to take a rollback like that. And so I just wanted to make those two comments and see more accountability on why or why not on doing some of the tribal leaders' requests.
Yeah, I appreciate both comments, and let me address both of them. We strongly oppose the rollback proposals. They're something that the President has spoken to, the Secretary has spoken to. We're advocating for more money. Those proposals are about less. We're advocating for more services. As you say, those proposals would require very steep cuts in services. We actually sent a letter to Congress that specified the amount of cuts that would be required in the Indian Health Service if they had to roll back to the 22 levels. We're proposing much larger increases than Congress is providing. So, as I mentioned in our 24 budget, we propose, you mentioned correctly, a $360 million increase in the 2023 budget. That was a fraction of what we asked for. Compared to that $360 million, we're asking this year for a $2.6 billion increase, so 8 times higher. And we want to do all we can to get as much of that as we can. To your points about administrative moving money around, I think we can and should talk about priorities within existing programs, and there may be grant programs where we can do more to create priorities for tribal nations, and that's something we should work hard on and be happy to talk to you more about. I guess I want to be candid in saying that there's only so much the Secretary can do through administrative action. There's very limited transfer authority that he can engage in unilaterally. That's pretty much used like when there's abrupt changes. I don't think it's used to accomplish, to my knowledge, ever to accomplish sort of major changes in the allocation of funding and where dollars are going. That's what we use the appropriations process for. That's what we go to Congress for. And as I said, when we have gone to Congress, we've asked for these very, very large increases. So I want to be acknowledge you obviously know a huge amount about this process, and you're spending a ton of time on it, and I'm grateful for that, and you're doing it. And I think continuing to push us and push Congress is a great thing. And we will do all we can. And I think we should look harder, as you said, at existing programs. But I also want to be just honest in my perception of like what we can do and what we can't.
I just want to tag on to this conversation a little bit. About 20 years ago, I remember hearing a tribal leader, and it was upstairs in the room, asking for our 2% why don't HHS just direct fund us, tribes at 2% of the HHS budget is what the trust responsibility should be, and divide it up between the IHS system, because it divides it up pretty well. I see other states of emergency happen in this great country that we have, and also even outside this great country, where catastrophic emergencies happen out there in the world, and the Department of HHS deploys people out to those areas, and they spend billions of dollars to try to save lives. Right here in our own country, we've declared states of emergency on the IHS budget. I did that, and it went from our Portland board to AT&I, from AT&I to NCI, and declaring a state of emergency on the IHS budget, because our people are dying. If you add up all our people that we're losing every year compared to some of these big catastrophic emergencies that are out there, you'll see our numbers are probably even higher. It's inhumane, how we are treated, and the IHS budget's pennies on a dollar compared to what the overall HHS budget is. And you can do the math all you want. We're tired of burying our people. I came here one time, and they had a town hall meeting. Young secretary was up here, and we had audience here, and a young girl from Pine Ridge got up and says, I'm tired of hearing well, we got to do this or we got to do that. But there's no action. Nothing has changed. It hasn't changed in the 20 years that I've been here, other than this administration, I will say, is the best one that I've ever worked with. You guys have brought forward some really good requests to Congress. The advance appropriations and mandatory funding are really good. The only downfall to the advance appropriations, that should have got an extra kick for the second year because it don't keep up with medical inflation and population growth. It's kind of like a bill where No Child Left Behind was never funded. The IHS has never been really funded to what it should be, never kept up with medical inflation.
Yeah. I appreciate all you're saying, and can't, none of my words are going to be equal to the challenges you've described or the history you've described. Let me just take a minute, and then we can continue to talk about the administration's proposals, because as you say, I appreciate the kind words. There's a lot of progress that's been made and a lot of good progress we're trying to make. So as you mentioned, 2024 for the first time is what's called advance appropriations, which means that in the situation of a continuing resolution, you don't get more money, but you also get money. Much of the government shuts down if there's what's called a continuing resolution. That means there's no agreement on a budget. I'm sorry, let me restate. If there's a government shutdown and there's no agreement on a continuing resolution, which unfortunately has happened many times in the last decade, agencies like IHS have to stop providing services. Very harmful. You've experienced that. For the first time, because of advance appropriations, that will not happen if there is a shutdown. The money is there. The Park Service will shut down here. Lots of government offices will shut down. There'll be very minimal services left, but IHS will be able to continue doing what it does. And so that's an important thing that happened in last year's budget. As you said, sir, that's only a piece of what we want to accomplish. What we actually want is mandatory funding, which means you don't have to go through this annual process at all. There's just money there year after year, like for Social Security or like for Medicare. And you would have the money go up in a reasonable way. And if you look at what we actually proposed in the budget, it's an increase of almost $200 billion in funding for IHS in that mandatory proposal, $200 billion. So that's what we're trying to accomplish. That's what we're trying to get. I think with this Congress, with people who are actually advocating to cut funding and to go backwards, it's very hard to go forward in that way. But that's where we're trying to go. Where we're trying to go if we can't get mandatory funding is to say we want a huge increase in annual funding. We want an extra $2.6 billion. And within that $2.6 billion is lots of increases for increased services, over $700 million for services on the front lines to provide more screenings, to better use data, to just have more doctors and nurses and mental health professionals, people who deal with substance use disorders, to have all those people, more of them, more services available on the front lines. There's a huge increase. This is wonky but really important. Electronic health records. IHS's system is really old. It's got to be replaced. If it's not replaced, it will have very harmful effects on patient care. So there's a lot of money just to fix that. There's more money for facilities, just improving offices, the places where people go, where they spend time. Significant increases there. There's more money for the cancer moonshot. There's more money for behavioral health treatment for people challenged with mental health. Substance use disorders. More money for substance use disorders. So those are some examples of the increases that are included. There's some bigger chunks that I will just briefly talk about, and then happy to go back to just having a conversation. There's increased funding for the Special Diabetes Program for Indians, which is an important program, longstanding. We want to reauthorize it. We want additional resources. There's more funding for the Administration for Children and Families Administration for Native Americans, which includes investments in language preservation, which are things that we're proud of and proud to be able to support additional funding for. Then there's some general funding increases. Oh, sorry, let me just do a couple more specifics. There's more funding for the treatment of HIV and hepatitis C in Indian country. And there's more funding, I talked about workforce, nurses, scholarship funding for medical professionals, places for them to live. Then there's just some general programs that are important to Indian country. They're important to the rest of the country as well, where there are big funding increases. I'll just mention a couple. One of them is the direct care workforce. So you talk about people with dementia. The people who care for people with dementia, people with developmental disabilities or physical disabilities, everywhere in this country, they are underpaid. Because they are underpaid, there's huge amounts of transition in the workforce. There's not enough people doing the work. So there's a huge investment in funding that workforce so they're paid in a fair way. So there's career pathways where they can earn a good living and want to stay in that career and not think correctly that they could earn more money in a much easier job and have more of those people. So that's a huge investment in the care economy. There's huge investments in child care and preschool in our agency. And then there's basic investments in things like energy assistance, just keeping the lights on, keeping the heat going when you need that. So that's some sense of what's in the budget. Big picture doesn't begin to meet the needs that Councilmember Joseph, you spoke about, but I think they are steps in the right direction and things that we are going to try to get as much done as we can this year. It's not a great environment in Congress, but we're going to try to do as much as we can. So with that, happy to return to comments and discussion. Yes, please.
I don't think you really answered my question a while ago, like for the data, where do we go? But I also have one last thing. Autism is big in our tribe, and I didn't realize probably after the pandemic, after it started getting out more. I mean, I have families with like 2 kids in there. I have one. They both have 2 boys, and then I have a woman that's got 3 kids with autism, and they're at different stages. And then I know some other ones, and I didn't realize it was so prevalent. Is there any agencies across HHS that help deal with autism, and who is that?
Yeah, so there's a few agencies. There's what's called the Administration for Community Living, which supports families who are supporting people with developmental disabilities, including autism. And so they are providing, they support the workforce that works with families facing those kinds of challenges. The National Institutes for Health, NIH, does a tremendous amount of research to try to learn more about conditions like autism, and so that we're better understanding what it's about. Obviously, that word encompasses a huge range of people with different kinds of needs and gifts and challenges, and so learning about ways to support those families. I think those are probably the 2 places. Administration for Children and Families funds programs that serve kids, Head Start, which also serves children with autism and has special services that aim to support children with special developmental needs. So those are some things at HHS. And then, of course, you have, not here, but the Department of Education, you have this administration proposing very large increases in funding for programs serving children with special needs.
Hi, I have comments. Hi, my name is Shauna Hicks. I am the Tribal Health Administrator for the Shoshone-Paiute Tribes on the Duck Valley Indian Reservation. We are located exactly on the border of Idaho and Nevada. We're very rural. We're 100 miles from the nearest hospital or ER. My question is, I guess I would like to know, we have received our AFA funding, $8 million, since I started working there since 2003. It's always been the same exact. We're tribal, but we had expanded our services out further into Idaho. The nearest, I believe, IHS clinic there to us that I know of is either Elko, Nevada, or to Fort Hall, that I believe they're IHS. But we've expanded, and now we are absorbing and picking up more Native American, Alaska Natives that are living in Idaho and the Boise area, around that area. So how do we go about requesting for increased funding, because we are picking up a lot of those. I believe our tribe not only takes care of our tribal members, but we also take care of a lot of members that are within a federally recognized tribe that are living in that area. So how do we increase that? Because I believe we're our tribe, we like to take care of just our Native American people in general.
Yeah, I appreciate that, and I understand that what you're describing is that you have a fixed amount of funding year after year, but the needs that you are meeting are growing and aren't even limited to your own tribe. I don't know the answer at this moment. I don't want to make something up. Okay. I think we'd be happy to get more information about the particular program and help to connect you with the right person within HHS.
And then along with hearing about the data, you know, I'm a statistics person as well, and with data, we want to make sure, where do we give our data, where do we send that to, so that our data is included as well. And then you talked about sharing tribal innovations and what works in your community. So we are short-staffed. We have hardly any behavioral mental health, and we have a high rate of suicide in our community. And so we are having to do kind of create our own innovation. And I think I've heard, going back to kind of like traditional healers in our community. And so we would like to also get reimbursed for those, because we are having to do what works for us and to use all our resources that we have in our community. So now we're having to revert back to some traditional healers, spiritual healers, community care providers, just to be out there in the field to help our people. And I guess this goes to so yeah, those are some of the things, you know, that I would like to bring to the table, because these are things that I think we need as in our Indian country, to bring those kinds of things back, because we don't have professionals that are going to go out there willing to work 100 miles in the middle of nowhere that we were placed at.
Yeah, I appreciate that, and I hear both that it's coming from shortages and limited access to the standard forms of medical treatment in this country, and also that the traditional practices have very important things to offer that I think everyone has a lot to learn from.
Yeah, we're so, and again, and then it just leads me to, you know, a lot of the criteria, regulations. It feels like we're just kind of bound and tied to those, and we have to do what we can to take care of our people out in the middle of nowhere. Thank you. We also have a high increase in our cancer, as well, and so we're dealing with that. You know, we're only 2,000, pretty much our population, and about 1,200 members, but we have a high rate of cancer patients too. Thank you.
Thank you.
Zombe Chua, Claudia Washke from the Shoshone-Bannock Tribes at Fort Hall, Idaho. And piggybacking off of what Mrs. Hicks has stated, in the state of Idaho, the federal requirement for continuous Medicaid enrollment, that deadline was March 31st of this year. So Idaho has now gone through, what they're doing is expunging their rolls for Medicaid. They started it as of last Friday. There's 150,000 people in the state of Idaho. A lot of those individuals are from our Native American tribes, because they can't get a hold of these individuals to make sure that they're doing their re-enrollment for Medicaid. But a lot of our Native families, they live in multiple households, so getting them their mail for those enrollment forms are hard. We've been trying to advocate for our tribal members to, you know, pay attention to your mail as it comes through. But a lot of times that mail gets lost because they might have moved from one household to the next household. And that trust responsibility for those who are on Medicaid, those who are most in need, our poverty families, you know, they're going to be expunged from these Medicaid rolls. And when they're seeking services, they won't know they're no longer eligible for Medicaid until they get that medical bill from a provider saying, you now owe us, because Medicaid no longer has them on their rolls. I mean, for that trust responsibility for the federal government to make sure that our Native people have that medicine, let alone being able to see a doctor, it's very important for us as tribal leaders to make sure that we're getting information, but it's also, I have not heard anything from IHS coming out and advocating to our membership, hey, we need to make sure that you're re-enrolled onto the program. There is nothing coming out of IHS. I heard this myself from our own tribal health representatives, but they're limited as far as what they do. Almost everybody goes through IHS for services, but IHS is not providing that information.
Yeah, I appreciate everything you're saying. I will follow up when I get upstairs about the question of whether there's more this administration can do to support continuous enrollment, maintaining Medicaid enrollment for tribal members, given, as you say, the special trust responsibility. The process you describe, unwinding the end of guaranteed enrollment through the pandemic, is it's required by law. Number one, we don't have a choice in the matter. Second, I guarantee you, the number one priority for the people who run Medicaid in this administration is trying to make that process run as well as it can, and trying to enable people to get the information that they need, and so that the mail doesn't get lost, as you described, because if someone is eligible, they should be able to stay in the program, and we deeply want that to happen. And our people have been working around the clock for the 2 years that we've been here trying to make this process work well. The unfortunate thing is that it's run in partnership with states, and some states want and are doing everything they can to make it a success, and some states are happy to see their Medicaid rolls go down. That's just the unfortunate reality, and we don't choose the governors, we don't choose the state legislatures, and that's just where we are. And so I can promise you that there's a huge amount of effort and passion around trying to make this process work as well as it can, but that at the other end are people who don't work for us.
Robert,
and that's the challenge.
I need to do the hard stop thing now. I'm sorry to cut anybody off, but we have a swearing in that has to take place, and they're ready to get that going here now. So sorry.
Thank you all for having me.
Thank you. Appreciate it.
Good afternoon, everyone. All right, a little better. Hello again. My name is Marvin Figueroa. I'm the Director of the Office of Intergovernmental and External Affairs, and I have the distinct honor of introducing Secretary Javier Becerra. You know him well. He's been a champion for Indian country, not only during his distinguished service in the U.S. House of Representatives and California Attorney General, but also since being confirmed in 2021 as the 25th United States Secretary of Health and Human Services. His commitment to Indian country is unquestionable. It's in his commitment to improve tribal access to public health care data. It's in his commitment to tribal language preservation efforts, but also his commitment to advance appropriations that result in his inclusion in the FY 2023 Omnibus Spending Package. I could go on, but I know he wouldn't want me to. So with that, I introduce to you Secretary Javier Becerra.
Assistant Secretary Figueroa, thank you very much. Assistant Secretary Contreras, thank you for being here. And to the family of Ms. Kunesh, thank you so much for taking the time to be here. All of you from STAC, appreciate the work that you are doing. Always a thrill to be with you. We're here for a very special reason and occasion, and that is to give Patrice Kunesh an opportunity to be in front of you, to let you know that we finally have our commissioner at the Administration for Children and Families who will deal with Native American affairs, and we are thrilled to finally get to do that. So I get the honor of making it secondly official after the President of the United States. And so I'm going to ask Patrice to please come forward. I'm going to make sure I tell her what to say the right way, so that way it's real. And let's come over here, Patrice. I'm going to put this down. thank you very much for holding the Constitution. Patrice, I'll ask you to put your left hand on the Constitution, your right hand up, and repeat after me. I state your name.
I, Patrice Kunish,
Do solemnly affirm
do solemnly affirm
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
against all enemies, foreign and domestic,
against all enemies, foreign and domestic,
that I will bear true faith and allegiance to the same,
that I will bear true faith and allegiance to the same,
that I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties
discharge the duties
of the office
on which I am about to enter. So help me God. So help me God.
Congratulations.
Oh, thank you so much. Thank you. Thank you, Kathy. Thank you.
Our commissioner.
Thank you very much.
And I think we're going to get to have family come up and we'll take a couple of quick photographs.
I have 13 brothers and sisters, so this is just a sampling.
Let's get over by the
Okay.
Commissioner Kunish.
As we clear the podium, I would like to now introduce Assistant Secretary January Contreras.
I'm going to invite our new commissioner up here momentarily, but did just want to say how proud we are to have someone of Commissioner Kunesh's experience, her leadership, her heart. She has served at so many levels to live out the spirit of why the Administration for Native Americans was created in the first place. As I've had the opportunity to interact with so many tribal leaders in my 1 year here, one thing I keep hearing about ANA is it's the hidden gem, that it is the agency that distributes grants that are truly tribally driven, that it is an agency that lives out the self-determination, the sovereign nation principles that we are also committed to. And in the couple of times we've already had to spend together, I hear that spirit and that commitment of Commissioner Kunesh to live that out entirely. So she's working like we all are with a sense of urgency to listen and to get as much done as we can together. And it's really my privilege to welcome her to our leadership team, especially in this role, and to ask her to just share a few remarks herself.
Wopila Tanka. Wopila Tanka to all of you for being here today to celebrate with me. Wopila Tanka to my family who've traveled very far to be here. Wopila Tanka to our Assistant Secretary and to our Secretary whose leadership and courage just inspires me every day. I'd also like to say, He hani washte nitchakuapi, shante washte timeheyoyo. And it is a good day. In the language of my Lakota relatives, I just want to celebrate that this is a really good day, not just for me, but all of Indian country. And we come here with open hearts to really do the work of Indian country. And as I was thinking about my remarks today and the event and the importance of what was happening, I would just like to share two small stories of what really has brought me through this journey to this place now. When my grandfather was born on the Fort Berthold Reservation of the 3 affiliated tribes in 1902, he was not considered a U.S. citizen. And back then, for many years, not till 1924, were Native people not considered full members of our society. And then had to struggle, decades later, for that participation. And here we are today, leading organizations, leading tribal nations, leading federal agencies and state agencies. So I'm Wopilatanka for that. Another story that reminds me of my journey here is a great aunt, Josephine Gates Kelly, who attended Carlisle boarding school at some of the darkest days. She did learn some very good lessons and went back to Standing Rock and became the first woman chief to lead Standing Rock at a very difficult time during the termination era when they wanted to take away tribal status, government-to-government relationship. Well, she actually hitchhiked her way to Washington, D.C. and hoped to meet with President Franklin Roosevelt. He didn't have time to meet with her, but Eleanor Roosevelt met with her. And while she didn't secure the much critical needed funds that she needed for her people, she was able to secure a promise that Eleanor Roosevelt would try to act on behalf of all of Native people to provide additional funds and resources. And then she gave her a train ticket back to Fort Yates, South Dakota, or North Dakota. So here I am today in the middle of budget consultation with our tribal nation leaders, and I am just so honored, so privileged to be here and among you, working together to advance the mission, the goal that my great aunt had way back when. So again, thank you, and Wopilatanka, it's a good day.
Hi, everyone. This concludes our swearing-in ceremony of Commissioner Kunish. We will now have a short intermission before we resume the tribal consultation. Thank you all for being here.
Produced by the U.S. Department of Health and Human Services.